Welcome back. This is Ian Bodford.
And Liang Liu.
And this is the Clinical Correlation.
Today's case is
Stuck in the middle with you.
This is a 2-year-old male with no significant past medical history who presents with vomiting and is refusing to eat. He has also been telling his mother that his throat hurts.
He was playing inside of the kitchen unsupervised a couple hours ago, and his mother noticed the junk drawer was open.
Vital signs are essentially unremarkable. On exam, he is a healthy-looking 2-year-old who has met all of his milestones. He has no wheezing or stridor. He also has full range of motion of his neck.
You decide to get a quick 2-view x-ray of his chest, and just as you suspected, he has swallowed a foreign body.
But now what? Surgery? Endoscopy? Let it pass on its own?
Swallowed foreign bodies is a common emergency department complaint and can be life-threatening. Around 1,500 people per year die from foreign body ingestion. 80% of swallowed foreign body cases are in the pediatric population, with prisoners and psychiatric patients making up the majority of the rest.
Children tend to ingest things that are easily accessible, like toys, coins, pen caps, and crayons. Adults have issues with meat and bones. Psychiatric patients and prisoners swallow unlikely objects like razor blades and spoons.
Generally, most objects will pass through the GI tract spontaneously. However, up to 20% will require some type of intervention, with 1% requiring surgery. The object can get stuck anywhere in the tract, but there are several narrow spaces, especially in the esophagus.
The most common site of obstruction is around C6, also called the cricopharyngeal narrowing. Other areas of physiologic narrowing are at T1, T4, T6, and T11.
T1 is known as the thoracic inlet. T4 is where the aortic arch crosses the esophagus. T6 is where the trachea bifurcates. T10 to 11 is the hiatal narrowing, which is also where the lower esophageal sphincter is.
If an object passes the pylorus of the stomach, it usually will be passed into the stool. If the foreign body is sharp or is irregularly shaped, it can become lodged in the intestines. If an object lodges in the esophagus, this can lead to obstruction of the airway, perforation leading to mediastinitis, cardiac tamponade, or a fistula between the esophagus and the trachea and/or aorta.
If a foreign body becomes stuck in the esophagus, it will likely cause anxiety and pain, including retrosternal pain in adults. It can also cause vomiting and dysphagia. Be sure to evaluate if the patient is able to handle their secretions. Adults generally provide the history necessary to make the diagnosis.
This may not be true in the pediatric population. Symptoms in children include vomiting, refusal to eat, neck or throat pain, increased salivation, and stridor, also known as pseudoasthma. Be wary of any pediatric patient without a history of reactive airway disease who comes in wheezing.
Your physical exam should include listening to the lungs, looking in the oropharynx, palpating the neck, and a thorough abdominal exam looking for peritoneal signs.
Evaluating swallowed foreign bodies usually requires some type of imaging. However, it may not be needed in food boluses. A chest x-ray with 2 views should be obtained, plus or minus a KUB when appropriate.
Swallowed bones are seen in less than 50% of radiographs. If no foreign body is seen but suspicion remains high, a CT scan can be performed. It has a sensitivity of greater than 99%. Barium swallow is no longer recommended due to the risk of aspiration and mediastinitis if perforation is present.
On x-ray, coins in the esophagus will present their face on AP or PA view. If the coin is in the trachea, it will present its face on the lateral view.
Bottom batteries have the classic double ring sign, or target sign on x-ray. Ingested button batteries are a true emergency if located in the esophagus.
The reason it is an emergency is because when both sides of the battery make contact with the wall of the esophagus, a current is generated. This leads to injury to the mucosa and can lead to perforation in as little as 6 hours.
There is also a national button battery ingestion hotline available 24 hours a day to help manage these patients.
Sharp objects or long objects are unlikely to pass into the duodenum if longer than 5 centimeters or wider than 2 centimeters. Even if a sharp object passes into the intestines, up to 35% will cause perforation.
Therefore, a removal is required if proximal to the duodenum, and monitoring with daily radiographs if distal to the stomach.
Almost all food boluses will eventually pass on their own, but they should not be allowed to remain impacted for greater than 24 hours. Although there is no great evidence for its use, glucagon is the mainstay therapy in the emergency department for trying to help pass food boluses.
1 to 2 milligrams of glucagon is given IV or IM. It is thought that it relaxes the lower esophageal sphincter. Keep in mind that its main side effect is nausea and vomiting. This can lead to aspiration or perforation and may actually worsen the situation.
Carbonated beverages have been described to dilate the esophagus and can potentially pass small food boluses. Treatments that are no longer recommended are calcium channel blockers, benzodiazepines, nitrates, and meat tenderizers.
Body packers are patients who purposely ingest packets of drugs in order to transport them. Usually containing high amounts of drugs, rupture of even one packet can be fatal.
The patient's symptoms should be monitored and the Poison Control Center should be involved immediately. The patient might require whole bowel irrigation versus surgery depending on the type of drug and the patient's symptoms. Endoscopy is contraindicated as this can cause rupture of the packets and leakage.
Urgent endoscopy is required in several situations. These include complete obstruction of the esophagus causing pooling of secretions, ingestion of button batteries, sharp or elongated objects in multiple foreign bodies, evidence of perforation, presence of the foreign body for more than 24 hours, and symptoms of airway compromise. Children with obstruction at C6 or the level of the cricopharyngeal muscle should undergo urgent endoscopy.
If the patient ingests multiple magnets, this is also an indication for urgent endoscopy as these can trap the bowel. Know who performs emergent endoscopies at your facility. It is usually either ENT or GI.
To summarize, there are several areas of narrowing in the esophagus. Management of the swallow foreign body can depend on the location.
Always be wary of the wheezing child, especially if they don't have a history of asthma or reactive airway disease.
Know what a button battery looks like on X-ray, and don't mistake these for a coin as button batteries can cause perforation of the esophagus in as little as 6 hours.
There are several indications for urgent endoscopy. Know these and who performs endoscopies at your hospital.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLU.
Thanks for listening.